That's one of the other strong components in book one. And I didn't mention, this is going to be a 4-book series, which I think is cool. You'll have some chronology there. We talked in a pre-interview a little bit about a couple things that I thought were good re-emphasis points. You mentioned how these things can affect gait. How does like a hand dominance affect right foot pain? Give me an example of that. And then I'll let you sort of expand on a couple things that you think are missed today with gait evaluation.
Well, in terms of hand dominance, that's something that is real interesting. So when people walk, if you're right-handed, your right foot should be looser and your left foot should be stiffer. It's your support leg. So you develop the muscles for support more than the muscles for motion. And so typically when I watch somebody walk, I'll see one foot pronating or, just wobbling more than the other foot that looks a little bit more solid against the ground. It could be more pronated and solid, but it's more solid. And when it's the opposite of right-handed, when it's the right foot that's solid and the left foot is loosey-goosey, I mean, that I would typically ask the patient right off the bat, are you left-handed? And they'll say, how did you know that? You haven't seen me right. So that's just one component. Now, there's so many things that affect that. You
mentioned too that you can be tricked by the muscle development and the curve in the shoulder. If you're just looking at the shoulder and not looking how the fingertips come down at the waist for right and right hand, both dominance and projecting forward or more towards the floor.
Yeah. So chapter 3 for everyone is the complete gait evaluation, which starts at your head and goes all the way down to your feet. And it's the number one thing that I've taught at the podiatry school forever, because I'm the one who teaches it. They all know that I know that world, and I get the most. If I could do nothing with the patient other than do one thing, I would do gait evaluation outside of everything. So I work. It's about 70 pages, I think, of the book, maybe less, but it works down and it talks about what does it mean if your head is tilted or your shoulder is rounded. So there's 2 reasons as we work our way down that the shoulder may look dropped on one side. Why it's important for podiatrists is that it's a sign. It's one of the signs of leg length discrepancy, having one arm that's lower as part of our leg length evaluation. And that's something podiatrists can treat really well. So when you see in a right-handed person, if you see the right shoulder that looks low and you're not sure if it's low or just rounded because of the musculature, you then look at the fingertips as it passes the leg from right to left. And in a true right shoulder drop, the right fingertip should be lower on that side. So that's sort of how you differentiate between just a rounded shoulder and a true shoulder drop.
The other thing I liked is how you connected some of the typical patterns. For instance, if you said, if we see, for instance, the right hip seems to be dropped, and you, I think, tied that into the lumbar spine and pelvis shifting to that side, you would typically expect the curve in the spine, it would first be, you would be dropped towards, let's say, the right side, but then the curve in the spine would go back to the other side. And then because it's an S curve, typically, you would then have the right shoulder drop and right head tilt to that side that is longer. So I guess the only side, if I got this right, would be the thoracic, which where the spine would be going to the left side.
Yes.
I know that doesn't always happen, but how frequently would you say that typically follows that that compensation pattern?
In adults, then it's about 80% of the time. So
Mhm.
kids that are growing, it's about 50-50, because in fact, if you follow kids and short legs, and nobody really treats children at too young with short legs, but some do. Um, you know, Sometimes the right looks a little longer, and then 2 years later, when they come in to check their orthotics, the left side looks longer, and then 2 years later, the right side looks a little longer. You don't know how they're gonna grow, but our legs grow asymmetrically. Um, but as adults, we tend to have the side that's higher. Um, so if we have a long left leg, let's say, then it's going to be the that it's that shoulder, the left shoulder, that drops down, and then our head's got to tilt level, so our head tilts back to the right. So the head tilt, if it's a normal pattern, is towards the short side. So
I want to sort of leave our viewers with kind of the two things that you would say you really want them to get out of segment one. What you've mentioned a lot of them, but are there any other things that you would really like to have the viewer sort of glom onto from segment one?
Well, I think with segment one, yes, it's starting with when you see a patient, take a good history, watch that person walk, and that's going to open up the that is being gait evaluation is being lost in that area. It's amazing how many people I see that have 4 years of history of a problem and no one's ever watched them walk. Podiatrists tend to watch them walk, but I think that's
Not always. Sometimes you'll just see them stand up and it's just that robot stance, just a snapshot,
right.
not the movie.
Yeah, so have them walk down the hall 5 times and get a feel of their motion. And there's all these apps now that you can even start using to start measuring angles and stuff. But that's one thing.
Do you have any favorite apps that you use for video, or do you just do a standard iPad video and slow-mo it?
Yeah, that's all I use.
I think you can get a lot of information out of that.
That's correct. That's correct.
Yeah.
Well, the end of the book, has the top 7 biomechanical examinations. So that's all going to, book 2 is going to have the complete examination, but book 1 goes through, the sort of the top ones that I use on a day-to-day basis. So that helps. And I think the last, the other one big point we haven't touched on is next to Occam's razor, which is the simplest thing, is the rule of 3, which is in chapter 2. And the rule of 3 is so important, and I find so many missing clues to a patient's injury. I'm looking for, like, if somebody pronates, they can get about 30 different pain syndromes. Their knees can hurt, their hips can hurt, their back can hurt. They can get plantar fasciitis, posterior tib, Achilles. You can blame a ton of things on pronation, and I look at that as one. So, but why does somebody who pronates, one person has shin splints, the next person has Achilles, the next person has plantar fasciitis. So then you got to look at 2 and 3. And that's what I call my rule of 3. And always look a little deeper. Shin splints is a great example. I had this guy who, UCSF, I wasn't supposed to mention names, but, major university, worked up for 2 years with his shin pain, couldn't help him. He comes in, I said, he doesn't have his records after 2 years, but I say, okay, shin pain is bone pain. Are you pronate? I actually had good orthotics from UCSF, and I'm pushing on his bone, and his medial shin was killing him. I said, well, have you ever had a bone density test? And he goes, yes, one time I had a bone density test, and it was low. And I said, did anything happen to that? She goes, yeah, I think I take 400 units a day of vitamin D. And so I had him get a bone density test. And at the age of 27, he had the bones of an 83-year-old. And it took him 5 years with an endocrinologist to get his bone density more normal with an osteoporosis guy. But this is somebody who I was his 12th opinion, and it was simple mechanics. Okay. Is it the muscle that hurts? Is it get the muscle strong? Is it the pronation that's causing the pain? You correct the pronation. Okay, what about the bone? Is it a bone problem?